Welcome, Dr. Bernstein.
Thanks.
Thanks for being here.
Thank you. Okay, this thing's on. Everybody hear me okay? Okay. So I'm going to talk, and this is sort of about testis cancer. Testis cancer is a very important cancer for obviously individuals and their loved ones if they have this, but it's actually a really interesting historical cancer. So this is a little bit of a history lesson in chemotherapy and oncology in general, in addition to a talk on testis cancer, because it's, this is actually the title of a paper that one of my mentors wrote, because we really do use testis cancer as a model for a curable neoplasm. Wow, this thing's, okay. So it's important because it affects men primarily ages 15 to 35. So they're in the prime of their life, and they have a long time to live if we can cure them. So they have a long life ahead of them. It is extremely treatable and very curable. So this is a cancer that we now do a lot of great work with. And just as importantly, with testis cancer, we established many of the basic tenets of modern cancer care. So the whole concept of rational utilization of combination chemotherapies. Many people who get chemotherapy today don't just get one drug. They get a combination of different drugs, and the whole way that we think about that is derived from the experiments that were done with testis cancer. The other thing is thinking about randomized clinical trials, which are very common now. That's kind of how we define whether or not treatments work. This was all worked out in cancer with testis cancer. Uh-oh, backwards. Okay, so how many people went to Harold Varmus's lecture? He was here pretty recently. Fantastic lecture, really interesting. And you know, he's a world thought leader in cancer, and he talked about the history and future of cancer research and talked almost solely about genetics and targeted therapies, which was very interesting. I mean, the guy had only a certain amount of time, but he really didn't talk about conventional chemotherapy at all. And that's what I'm going to talk about tonight, because a lot of really interesting things have been done with that. Not sure. Okay, there. So testis cancer is actually quite rare. There's about 9,000 cases a year in the US. The incidence is increasing, and we have absolutely no idea why. So we're seeing more and more testis cancer, but we don't understand if it's environmental or genetic or why that's happening at all. It affects men ages 15 to 35, and there's a small incidence after the age of 60. So rarely we'll see men after the age of 60 with testis cancer, but really from 40 to 60, you pretty much don't see it. It is more common among white men and less common among other ethnicities. The highest incidence in the world is in Denmark. So this is a picture of testis cancer under a microscope. And you know, I found this the most boring part of medical school when they put these slides up. And if pretty much what you need to get from this is if there's a lot of purple, that's bad. Purple small cells, that's bad, that's cancer, this is normal. So this is one of several types of testis cancer. I just put that up because people always want to know what it looks like. There are two big groups of testis cancer. So there's seminoma, which is one type, and that's what we just looked at. And then there are 4 non-seminoma types of testis cancer. There's embryonal carcinoma, there's choriocarcinoma, there's yolk sac tumor, and teratoma. And all of these start within the testicle. There are some other very rare types of tumors that start in the testicle. I'm not going to talk about those today because they're less than 5% of testis cancers, which are about 9,000 cases in the US. They're super rare. You need to go to a really specialized center for them, and that's really not worth covering. I wanted to talk a little bit about staging. So with all cancers, there's a staging system for where the cancer has gone, because it's not just important to know what type of cancer you have. It's just as important to know where it is. So stage 1 is when the tumor is confined to the testis or testicle. In medicine, we call a testicle a testis. I'm not sure why, but we do. Stage 2 is when the disease has spread to the lymph nodes, and it's a very predictable spread, so that it goes to the same side, and we know where those lymph nodes are, and so that's stage 2 disease. And testis cancer is more predictable than many other diseases in terms of the way it spreads to lymph nodes, such as breast cancer is less predictable than testis cancer. Stage 3 is when you have distant metastases, meaning the disease has traveled through the bloodstream to another site or another organ. So I wanted to talk a little bit about anatomy in terms of staging. It's a little awkward because if you're at a church giving a talk to the general population, full frontal nudity is sort of frowned upon, but I thought a squirrel with nuts. How could anybody have a problem with that? So as you can see here, testicles are surgically relatively easy to get to. And so when we take a testicle out for cancer, we do an operation called an orchiectomy. And you need to take the testicle out along with the cords that run up into the rest of your body from the testicle in case the cancer has spread to those cords. So we actually make an incision at the lower part of people's abdomen to take that out. And that's called an orchiectomy. So here, this is a picture of lymph nodes. So these are the lymph nodes. These are called the retroperitoneal lymph nodes. And when testis cancer spreads, the first place it usually goes to is these lymph nodes. And it is very predictable in that if you have a right-sided testis cancer, it goes to the right-sided lymph node. So I've seen patients who will have a slightly enlarged left-sided lymph node, and they had a right-sided testis cancer, and everybody gets all worked up. And I say, it's not testis cancer, don't worry about it. We will follow it, it gets better. So it is a very predictable spread to the lymph nodes when it goes to the lymph nodes. Now, this is an operation where we can take all of these lymph nodes out, but they're very inconvenient to get to. So these lymph nodes are not in your abdomen. They're behind the abdomen. So all your intestines and all that stuff, they're in the back. They call it the retroperitoneum because it's in the back. So this can be done in specialized centers, and there are people who are really good at doing this, but it's not an operation you want to just go to a general surgeon and have done. And it's a difficult operation that takes specialized skill. So this is an enlarged retroperitoneal lymph node from cancer. Pointed out, I don't know, if your vision is really bad, you may have missed this, but this isn't supposed to be here. The rest of this is normal stuff. This is a gallbladder, that's a liver, here's kidneys, and this is a giant lymph node from somebody's testis cancer. So we use CT scans to find these lymph nodes because they're hard to feel. That one, I could probably feel. Much smaller than that, you can't feel them because they're behind the intestines. So we talked about orchiectomy. We talked a little bit about this retroperitoneal lymph node dissection, and that's when you take all these lymph nodes out here. Now, one of the disadvantages to that is there are nerves there that are needed for ejaculation. And so if it's not done in the hands of very experienced professionals, you can lose that function. So another interesting thing about testis cancer that's very different than other cancers are reliable serum tumor markers. And what a serum tumor marker is a blood test that we can do to look for cancer. There's all these other blood tests that are kind of sort of useful for cancer. The PSA, which everybody used to tell you to get your PSA every year. Now we all tell you don't get your PSA every year because it gives us bad information as much as good information. With testis cancer, the markers are fantastic. They're very sensitive and specific for telling us you have testis cancer, you don't have testis cancer. So we use these extensively, and there's two that we use. One of them is called alpha-fetoprotein, or AFP, and it was discovered in 1956, and it is only elevated in yolk sac tumors and embryonal carcinoma. The other is human chorionic gonadotropin, or HCG, which was discovered in 1927, and it's elevated in embryonal carcinoma, choriocarcinomas, and rarely in seminomas. So we can not only tell if you have testis cancer, but sometimes we can even tell what kind looking at your blood work. Oh no. Sorry, I think there's a little delay here, and I am clearly not patient enough to deal with that. Okay. I think it's going to work out in just a second. Well, so the most famous testis cancer patient that I know of is maybe Johnny Appleseed. This is not really well confirmed, but Johnny Appleseed may have died of testis cancer. The one that had the most sort of famous testis cancer patient who has died that is confirmed would be probably Brian Piccolo. So he was an athlete. He was a running back for the Chicago Bears. The movie, anybody seen Brian's Song? It's like this really horrible, tear-jerking, good, but horrible movie about this young athlete who's just a fantastic guy. Everybody loves him, and he dies of this horrible cancer. He was 26 years old, and he died in 1970. So he was right before so many things changed. But this is an important example of if you were diagnosed with metastatic prostate cancer prior to 1970, it was a death sentence. Okay, everybody died. This was not a treatable disease, and it was horrible. Now, if you had localized disease, there was some ability to cure it with surgery. Because we had World War II, we had surgery prior to World War II, but we got really good at it, relatively speaking, during World War II, because there was lots of opportunity to practice. People come in with their bellies all slayed out. So surgical techniques improved to the point where we're able to reliably do retroperitoneal lymph node dissections. And patients who had disease that had spread to these lymph nodes, we could sometimes get them out and cure them. We also, around that time, had access to radiation. And we were using radiation to treat some of these tumors. But still, if you had metastatic testis cancer, 90% were dead at 1 year. So this was a pretty grim time for young men with testis cancer. It's going to go, it's not going to go. I feel like the clicker is maybe not. Okay, this is a big, scary radiation machine. I just felt like we're in Los Alamos. I should have some sort of scary radiation machine. Yeah, it's really scary looking. So, and as we learned more about testis cancer radiation, we found out that seminoma, one of those types of testis cancer, was very sensitive to radiation. So that patients who had disease that spread to their lymph nodes, if we treated them with radiation, they had a fantastic response, and we could cure the majority of those patients. It worked so well that patients who only had disease in their testicle, we would treat them with radiation just in case, because we couldn't reliably tell whether a couple cells had gone out. And the cure rate for seminoma with radiation for people who only had it in their lymph nodes was 95%. So radiation was a fantastic advancement for that subset of people with testis cancer. Unfortunately, for non-seminoma, not so good. So this is a trial from Memorial Sloan Kettering, 127 patients with non-seminoma they treated with orchiectomy followed by radiation, all of them dead within 2 years, 100%. So for non-seminoma, things were still grim. Until we had early chemotherapy. So chemotherapy is a term that actually used to be used for antibiotics. Imagine if every time you tried to give somebody antibiotics, now you called it chemotherapy. We'd be able to cut down all this excessive antibiotic use. But actinomycin D was an antibiotic that they sort of just figured out works for cancer sometimes. And they gave it to patients with testis cancer, and about 10 to 20% of those patients would respond, and 5% of them were cured, which sounds pretty abysmal, but when you go from 100% death to 95% death, gives you a little bit of hope. Okay, there's a tool there that's finally helpful. And the next one was periwinkle, which if I told people I gave them periwinkle, no one would be that freaked out. If you call it vinblastine, super scary. Then it's chemotherapy. And that came out in 1970. And when they gave people vinblastine, which is derived from periwinkle, there was a 32% complete response rate. So 32% of these men, their disease melted away, and 16% of those men went greater than 2 years with no evidence of any disease recurrence. So this was super exciting, okay? That's 1970. All right, so that went forward to, can we go back one? So cis diamino dichloroplatinum, very difficult to pronounce. We call it cisplatin, okay? I hadn't even thought about this compound ever until I was doing this talk, and I'm like, so that's, I guess, what cisplatin really is. But the story behind cisplatin is really cool. There was a guy named Rosenberg at Michigan State University, which I just think of as a big drinking school. But he was working on this project to see if electrical fields affected bacteria. And he had 2 electrodes in a petri dish. And the electrical, around the 2 electrodes, the bacteria disappeared. And he thought, I'm wicked smart. Electrical fields do affect bacteria. So he was duplicating his experiment for some other folks, and it did not work. And he figured out that he was using copper electrodes the second time, and he was using platinum electrodes the first time. And so it was the platinum electrodes that were inhibiting the growth of these bacteria. So they subsequently found out that this was an active ingredient maybe to inhibit growth of cells, and they tried giving it to animals, and it worked in some cancers, and then they tried giving it to people, which initially seemed like a horrible idea. These people got super sick. On average, they threw up 10 times a day. On the first day they were given this drug. Some of them had irreversible kidney damage, so their kidneys never worked again. And all of these patients ended up in the hospital, okay? And so that was 1971. But this opened up a whole new era of treatment. 9 of 11 of these patients, so this is 11 patients that they made just deathly ill, 9 of them responded. Now, no drug in any cancer had ever worked this well. Now, it was a miserable experience, but it was really effective. So this guy, who was my mentor in Indiana, this is the guy I trained under. This is actually why I went to Indiana. So he's kind of like the Oppenheimer of cancer. I mean, this guy put so much stuff together, and not by himself, but with his team, that he is like a living legend. I mean, it's super cool to work with him. And they called me Little E when I was there, because he already sort of Big E. But he did most of the trials that I'm going to talk about. And so as they were coming out with new drugs, he was looking at, well, how could we figure out how to use those drugs together to make them more effective? And this is where this non-overlapping toxicity thing comes in. So cisplatin is a horrible drug to take for your kidneys and for nausea and vomiting. Vinblastine is really hard on your nerves. You get neuropathy or numbness in your fingers and toes, and it's hard on your bone marrow. Bleomycin is hard on your lungs, okay? So we sort of hit different organs just kind of as hard as we can, and then we give you a different drug that is not hard on that organ, but it's hard on a different organ. It sounds masochistic, but it allows you to give drugs in a way that you wouldn't otherwise be able to give them. And so they gave this combination of 3 drugs for 4 cycles, and then they gave people just vinblastine for 21 months afterwards. And so this was a really good idea and the first really effective use of combined drug therapy. And we increased the cure rate from 5% when we first started using these chemotherapies now to 64%. Okay, so now we're curing the majority of men who have these testis cancers, whether it's seminoma or non-seminoma. So this was just this breakthrough, unlike anything anybody had ever seen in cancer. And it was really exciting. So in 1981, Einhorn said, okay, that was a great trial. I'm really, that was a third base hit. What can we do to make this better? And PVB is a difficult combination of drugs to take, causes severe nausea and vomiting, kidney damage, and severe nerve damage, which is basically just from the vinblastine. And the vinblastine you're getting for 23 months. I mean, it's this super long cycle, and it just gets worse and worse with the nerve damage. And so he thought, if you're not going to cure it with 4 cycles of chemotherapy, I think just throwing a little vinblastine at it probably doesn't make a difference. So he tried it without the vinblastine. And so he compared maintenance versus no maintenance, and there was no difference. So they got rid of the vinblastine. So this is a chest x-ray that is normal. Okay, this is what a normal chest x-ray looks like. You got your non-medical professionals. This is your heart. That's your aorta. These are lungs. These are the ribs, which are the good part in animals. Okay, this is a tumor, okay? Not quite as big as this patient's heart, but that is a big tumor in somebody's lung. Okay, these are multiple tumors in somebody's lung, okay? So these are old. This is 1979, okay? So these are right when we were getting effective therapies. This is a guy with multiple tumors throughout their lung. And this is a guy, I actually saw this guy in follow-up, okay? So this is in the, I don't know what year this is. I think this is probably late 80s. This guy's an Israeli helicopter pilot. He came from Israel to Indiana to get treated. He's still following up. So that is barely any lung, and that is mostly tumor with a little lung in it. Okay, so we were now getting some new drugs, and the next drug was etoposide, and it is podophyllatoxin, which is derived from the roots of the American mandrake. So after doing this talk, I also started to think of myself as a naturopath. Which I know is probably going to piss off a lot of naturopaths. But it's been used for a long time by Native Americans and Himalayans as an emetic agent. So if you want to purge, makes you throw up. And then also for treating worms, if you want to get dewormed. So it's sort of an old folk remedy that's been used for a lot of things. And it seemed to have some anti-cancer activity in animals, so we tried it in people. And sure enough, worked in testis cancer pretty well. And because we had this effective chemotherapy where we're curing the majority of men, you'd only give it to patients who'd already had that and failed. So patients who got treated with PVB and then had recurrence of their disease, we gave them etoposide. And we cured 23% of them. Okay? So this is in people who did not respond to triple drug therapy before, and that was 1985. So Einhorn said, well, boy, that seems like a really good drug. We should do that up front. He said, let's get rid of the vinblastine, and let's put etoposide in there instead. So BEP, bleomycin, etoposide, and platinum. And he treated 244 patients from 81 to 84. He gave them either PVB or BEP. 66% of those patients were cured with the PVB. 78% were cured with BEP. So this became the new standard of care, and it still is with some changes. So he then said, well, do we really need to do 4 cycles? So he sort of is intermittently increasing the intensity of chemotherapy or looking at new drugs and then revisiting this and going back and say, how can we do this without making people as sick? Because when you get BEP, your kidneys get beat up, your nerves get beat up, you can get damage to your ears where you lose hearing, or you'll get tinnitus, which is ringing in your ears, and it can also be hard on your lungs. So he designed a trial to compare 3 cycles compared to 4 cycles. And he took 180 patients with metastatic disease, and he randomized patients to either 3 cycles or 4 cycles. Overall, the cure rate was 92%, okay? Now, these are patients who had earlier disease because they hadn't been waiting for a new clinical trial, but still, this is a 92% cure rate for people with metastatic disease. And for patients who had an HCG, that's one of those serum tumor markers, the blood tests that we do, less than 1,000, the cure rate was 98%. Nothing had ever been seen like this for a tumor that starts in a solid organ. So, okay, so there were numerous other trials. Now, some of these Einhorn didn't do, but they thought, well, there's lung toxicity with bleomycin. What if we just get rid of that? Could we just do EP, or etoposide and platinum? And so they looked at EP times 4 times or compared to BEP times 3, and it wasn't quite as good. So BEP times 3 remained its standard of care. They then they've come out with newer platinum compounds that didn't cause as much puking, because there's a lot of puking with cisplatin back then. And carboplatin did not work as well. So then, thinking they could maybe do a better job, somebody said, hey, let's double the cisplatin dose. And that, while making people even sicker, did not work better. So we sort of went back to that BEP times 3 or 4. Okay, so if you look at what happened from 1974 to 1987, and 74 was a huge leap compared to prior to that, okay? So we really went from 5% to 64%. By 87, overall survival 92% and 98% in good risk patients. So we look at the serum markers and we define them as good risk. 98% cure rate for those patients. And the duration of therapy went from basically 2 years to 9 weeks, because we got rid of this vinblastine arm. It became much less toxic, and patients had an easier time with chemotherapy. So I talked a little bit about different types of testis cancer. And I want to go through that in a different way. Oh, wait. Is that right? Okay. So we talked about the seminoma, and that's sensitive to both radiation and chemotherapy. And then non-seminoma, I'm going to talk about these and talk about which ones are sensitive to chemotherapy and which ones aren't. Because teratoma is a different animal. It's very different than the other types in terms of how we treat it. Can you see that? Not really, huh? Nobody's laughed yet. It's either a really bad joke or it's too blurry. This is why communication is very important in medicine. It says, no, nurse. I said slip off his spectacles. And she's not holding spectacles. I'll leave it at that. Okay, so we have different types of treatment that work well on different types of tumors. We talked about seminoma being very sensitive to radiation, and then chemotherapy works fantastically well for seminoma, for embryonal carcinoma, choriocarcinoma, and yolk sac tumor. But there is another type of testis cancer, the teratoma, which doesn't respond to chemotherapy, and it doesn't respond to radiation. And so this is a little bit of a vexing problem, because chemotherapy is working so well for these other subtypes, but if patients have teratoma, it doesn't work for that. And teratoma is also special because it doesn't travel alone. But most cancers will go through your bloodstream. But I think of teratoma like a remora. Everybody know what a remora is? So it's these fish that travel on the sides of sharks, and they pick up the leftovers. So they don't have to swim. They're sort of fish of leisure. Okay, so they use this other shark to get around. And teratoma, what it does is it travels on the back, usually of embryonal carcinoma, but it doesn't travel on its own. It has to have another type of testis cancer to get from point A to point B in your bloodstream. And then once it's there, and you've had your other types of testis cancer cured by chemotherapy or radiation, it just sits there and grows. It doesn't go anywhere. And so as surgery got better, we got better at picking out teratoma. And this is really one of the very, very few cancers that we do this. If you have a teratoma that's traveled to multiple places in your lungs, we'll go through there and we'll pick it out. And there are surgeons who specialize in doing this. So there's a guy, Ken Kessler at Indiana University, and the urologist there, and they are really good at finding little spots of teratoma, getting them all out, and if they miss one, Well, it'll grow, you find it later, and you pick it out. So I've seen patients who've had 35, 40 things picked out of their lungs and their abdomen who are then subsequently cured. Doesn't happen with other types of cancer. Sometimes you'll take things out, but you don't cure it like that. So we've gotten much better at getting teratoma out. So because of all these great advances we've had in treating these cancers, we have some folks who, character notwithstanding, there have been some things more recently. You know, this used to be sort of like the Shining Indiana thing, and then now we're like, oh yeah, I mean, I knew that guy a little bit. But so, you know, Lance Armstrong presented with disease in his brain, disease in his lungs, disease in his abdomen, and he not only went on to be cured, but obviously his lungs weren't that damaged. You know, I mean, the guy is very functional and is leading a normal life functionally, but, you know, obviously extraordinary and then some lows. But, you know, people go on to do a lot because these are young guys who we go on and cure. So the next big advance was 1991. And in 1991, a drug called ondansetron was approved. Folks here will know it as Zofran. If you've ever had it, nobody ever prescribes ondansetron because it's too long to write. That's the brand name. But it was the first of the selective serotonin type 3 drugs. And it's a receptor antagonist. It binds onto this little receptor in your brain. And for chemotherapy-induced nausea, it is fantastic, okay? It totally changed the game. So that when we give cisplatin, when it first came out, on average, day 1, 10 episodes of throwing up. Today, the median number of vomiting episodes on day 1 is 0, okay? So, for instance, I gave a kid BEP who threw up twice. He had to get 4 cycles because he had a little higher risk disease. The 2 times he threw up were both after talking to me, going up to get his first cycle of chemotherapy. So he was just so anxious, he threw up twice. They gave him the antiemetics, he felt much better, and then he was fine. So the next big thing was actually more of an academic exercise. It was the formation of the International Germ Cell Cancer Collaborative Group, which is a horrible name, and there's so many G's and C's, and even the abbreviation looks bad. But they developed this risk stratification system in 1997, and they looked at the types of tumor people have, the primary site, because there are testis cancers that begin in your chest, which is a really confusing thing, but for any guy who's been kicked in the testes, that's kind of where it hurts, okay? And the reason is because that's where your testes start. They start high, and as you form as an embryo, they descend down. And so every once in a while, a cell will get left behind that's actually a testis cell up in your chest. So those patients don't do as well as patients who have disease that starts in the testicle. And then they look at metastatic sites and their serum markers, and we separate people into risk groups. So good risk group, over 90% cure rate. Intermediate risk, about a 75% cure rate. And patients who are in a poor risk group have about a 50% cure rate. So we're still working on some of these groups, but some of them we do extraordinarily well with. So what do you do if you're not cured after modern chemotherapy for testis cancer? Well, the next advancement was peripheral blood stem cells with high-dose chemotherapy. So we used to do bone marrow transplants in these patients where they'd actually go in and you'd have this, you have a handle with a needle on it that's hollow. It's like a little hand drill, and you would get core samples of bone marrow, and you'd get tons of these. You put them in the freezer. This is really primitive. Everybody does not want this done. So you put them in the freezer, and then you give people super high doses of chemotherapy that are very hard on the cancer, but they also kill your bone marrow. So you have no immune system. You then take the bone marrow, and you put it back. Okay, so that's how this all started. It allowed us to remove a portion of people's immune system that would then come back with those stem cells and repopulate after giving them really high doses of chemotherapy. Subsequently, we figured out how to give people stimulating drugs where we can actually harvest stem cells from your peripheral blood. So now, we give somebody some drugs, we put a needle in, we take out the stem cells, put them in the freezer, give them super high doses of chemotherapy, and then give them the stem cells back. And stem cells are super smart. They know they're supposed to live in your bone marrow. They go back to your bone marrow, repopulate things. It works a little bit quicker. It works better. So we don't really ever core out people's bone marrow to do bone marrow transplants anymore for this disease. And for patients who had failed chemotherapy, so these are people who had gotten treated with the best standard of care up to that date, we're able to cure, depending on the study, between 45 and 70% of these patients. So this was a great salvage tool for patients who had recurrent disease. I feel like there should be more slides. Okay, sorry. My slides are just really acting up. Okay, There's a summary. There it is. So, in summary, with testis cancer, it is really arguably the biggest success story of anything in oncology, at least solid tumors. I mean, we cure the vast majority of these young men who go on to live relatively normal lives. It's representative of how, it's sort of the pinnacle of what can be done with modern chemotherapy. There are other diseases that we can treat very effectively, but when they're metastatic and have spread throughout your body, they're very difficult to cure. And it served as a model for how to think about it, how to think about non-overlapping toxicities and thinking about what might work next, and how to use randomized trials to figure out which things work better than the other things and get to the best solutions for problems. I think that's it. This is my really bad Star Wars joke just because I had this. Oh. Sorry, I don't know what's going on with that there. It's not very funny. There's a big Death Star. It doesn't look so good, little Death Star that looks normal. And it says, I think the Empire should get that checked. So yeah, that's sort of the whirlwind tour of testis cancer. Linneber? Yeah. So young men don't like going to the doctor. There is a sort of a big PR campaign about checking your testicles regularly. Most guys just notice something a little bit different. They'll notice a nodule. Anybody with a firm nodule on a testicle needs to have that checked out. So it's actually on the little sphere of the testicle. The veins that are attached to it, people will get something called a varicocele most commonly there. That doesn't worry you that much. But anything that changes with the testicle itself needs to be examined by a physician, and they should have an ultrasound done. For men who present with more advanced disease, I've seen people present with back pain because it's spread to the retroperitoneal lymph nodes. Occasionally, we'll have patients who have a cough and shortness of breath because their chest is full of cancer. That's pretty uncommon, but it can happen. And the problem is that young men get back pain really frequently. I mean, if you sent every guy with back pain for a CT scan, but if it doesn't get better, it needs to be something that you think about. And the nice thing is that if somebody's over 40, that's not it. I mean, I've seen very, very few patients, a couple like who are 42, I think is the oldest I've seen, until you get over 60. So it really is, in patients age 15 to 35, you need to sort of think about that. And any change of the testicle itself needs to be evaluated. Yeah. In the blue shirt?
How easily is it to detect in stage 1?
If you check your testicle, it is pretty easy to find. So the majority of patients that we see now are stage 1. And it's pretty easy to see. I mean, you can feel it. You can't see it until it's quite big. I mean, I've seen, young guys don't come to the doctor. I mean, I've seen guys with a very large, they'll have one normal testicle and one like grapefruit.
A lot of cancer are sensitive to heat. Cancer cell are sensitive to heat. Has there been any investigation into use of ultrasound?
In terms of treating it?
In terms of treating, not diagnostic.
Yeah.
I know that it could be used for diagnostic, but the question is, focus. Basically, it's a highly focused, intense ultrasound, which basically will raise the temperature of the tumor cell to a high, very localized to a high temperature.
Yep.
Has any study been done in that area and whether it's effective? Or?
Not with testis cancer, because the place that would be most applicable would be in the testis itself.
Yeah.
But usually have two. And so rather than taking a curative modality that works 90-something% of the time and sort of trying something else, you would have an orchiectomy and have it taken out. Part of that is that heat or doing something locally to the testicle may actually allow it to get out into the scrotum, which you do not want. So you want to kind of take the thing out as a whole testicle. We've used stereotactic radiosurgery for patients who have very difficult to treat metastases, so disease that's spread. I'm not aware of ultrasound ever having been used to treat testis cancer. It's used to detect it all the time. I mean, that's sort of the first test you do is a testicular ultrasound.
Well, are you aware of that being used in prostate cancer?
Oh, the ultrasound?
Yes.
Yeah.
Okay.
Yeah.
So what's the differentiation between the ability to use it in prostate cancer and not here?
Well, that the cure rate with surgery in testis cancer is extraordinarily high, that you have another testicle, so you don't really need the prostate. I mean, you don't really need the one testicle. I mean, you don't want to get rid of it for no reason, but rather than risk lowering your cure rate, you would rather leave one testicle there and take one out. And, you know, prostate cancer they're just totally different animals. Yeah, I mean, the prostate is a difficult area to do surgery in because it can affect both sexual function and urinary continence. So we really want to avoid doing surgery there. With testis cancer, it's a little hard because patients really want to avoid you doing surgery there. But it's a very relatively easy surgery to do, and it shouldn't affect their function.
I know that back in the late 80s, I know that back in the late 80s, they were talking after one testicle was removed of putting in an implant. Are they still putting in the cosmetic implant?
They are. So you can still get those. Yeah, I mean, I've seen a lot of them. It's interesting, you know, I think I'd say the minority of men opt for that with the first testicle. I feel like with the second testicle, it's a much higher percentage. But yeah, they're available. They've been used for a long time.
When they do the peripheral stem cell, you know, and take them out, is that you have to go to a highly specialized place like Sloan Kettering or Texas, or do they do it anywhere around here?
They were doing them at UNM. I don't know that they are. I think that program was there and has stopped. If I had to get one, I would go to a place that does a lot of them. I mean, it's a kind of thing that is protocol based, and you want to make sure that they have really good air filtration. Like, you know, you read about these cases of, all these people got a fungal infection because there was construction going on next door. Nobody thought about that was where the air was coming in.
Not Texas, then.
Yeah. But you want to go to a center that does a lot of them.
Are there any warning signs, or would physical injury or vasectomy, anything like that, increase the risk of cancer?
No, so the things that increase the risk of developing testis cancer, if you have an undescended testicle. So men who had, like, you would find this out from your parents, because when you're very young, your testicles start up pretty high and then they sort of drop, and some testicles don't drop. And so if you have a testicle, like, what will happen is your pediatrician will notice that one of them is missing. And then they'll do an operation to bring that testicle down. Those men are at increased risk to get testis cancer. If they never bring it down, those men are also at increased risk for testis cancer, but it's harder to find out because you can't feel the testicle. So that's really the biggest risk factor is cryptorchidism, which means the testis didn't come down. There are certain families that have a lot of testis cancer, but in terms of physical injury has not been proven to really correlate with testis cancer. Same thing with bicycling. You know, it's not, I was involved in an interesting lawsuit in Oregon because they have cancers that if you're a firefighter, they're just covered. Okay, so if you're a firefighter and you get lung cancer, doesn't matter if you smoke or not, that's considered a work-related thing. You not only get your health care paid for, but you're on disability. Like, you know, you're on it's not disability, it's work-related injury kind of a thing. And so testis cancer was included in this because they've done studies that show the incidence of testis cancer in firefighters is super high. Well, if you were looking for white males, age 15 to 35, where would you go? You go to a fire station, right? I mean, so it's like, you know, there's no women, so you've doubled your risk of getting testis cancer. And so there's no really convincing data that that's true, but there are studies saying that the incidence is much higher in firefighters. It's like, yeah, I don't know what to do with that information.
What other questions are there?
Anybody else?
I apologize for this question, but I got to ask, what is a yolk sac tumor? I mean, isn't a yolk a component of an egg?
Yes.
Okay.
So It does not look like, I mean, I've seen yolk sac tumor underneath a microscope does not look anything like an egg yolk. But it is, when you look at a testis, there are different characteristics of tumor. I don't know why they call it a yolk sac tumor. It doesn't look like an egg or a yolk. But yeah, it's a good question that I don't have an answer for. I could sort of like do an interpretive dance of what it looks like. And it would not look like an egg or a yolk. I don't know why they call it a yolk sac. I'll have to get back to you on that.
Great questions.
Oh, one more?
Is the ultrasound diagnostic for a testis cancer?
Almost. So the ultimate diagnostic tool is surgery. Because seminoma usually does not have elevated markers. And so if you do an ultrasound and you see a solid mass in a testicle, it is testis cancer until proven otherwise. The only time that the right thing to do is not to cut that testicle out is if it is the last remaining testicle. So patients who have had testis cancer are at a much higher risk. There's about a 5% chance they'll have a second testis cancer. And in those patients, when you see something on ultrasound, we will actually take the testis out. So we'll go in, do the orchiectomy basically, get that little thing that we see, make sure it's testis cancer, and if it is, your options are either to put part of the testicle back in or take the whole thing out. But in the vast majority of men who have a solid nodule in a testicle, it is testis cancer. So it's as good a test as we have, short of taking the thing out. Yeah, there.
So is a biopsy ever indicated for testis
Almost
cancer?
never. So this is a good thing to know as a primary care doctor.
Is there risk with
Yes.
doing a biopsy and spreading?
There is. So the testis is not a yolk sac, but it is kind of a sac, okay? It has this thing called the tunica albuginea around it, which is a fibrous sac. And it's really nice in that unless somebody screws this up and does a biopsy or takes the testis out the wrong way, you really don't see testis cancer in the scrotum. Okay, it pretty much doesn't spread there. If you go in and you biopsy one, it might. And then it can get into other places. It would just introduce a mess. So that you pretty much don't biopsy it unless you're at a very specialized center, it's the only remaining testis, and you're trying to see if you can preserve that so the patient doesn't, either can preserve fertility, which when you're on the second testis with testis cancer, the odds are relatively low, or they can avoid needing testosterone supplementation because the remaining testis will make testosterone. So if you have a surgeon who calls you up and says, oh yeah, no, I saw that patient with the abnormal ultrasound, I can get a biopsy of it tomorrow. Say thanks. Call your patient, tell them to go somewhere else. Because that's not the right thing to do. Okay?
Great questions. Anybody else? Oh,
So how does it affect you afterward with having children thereafter if you had one taken out?
Yep.
Does it reduce your chances? Or do you just supplement them with?
It's a complicated question. So there's two problems with that. One of them is the surgery, which really doesn't affect things much. Okay, so men with one testicle should be able to have children without much difficulty. But testis cancer itself affects fertility. So men who have testis cancer will be less likely to be able to produce normal sperm. Now, most men who have testis cancer can still produce normal sperm, but some of them can't. That's the biggest predictor of whether or not they'll be able to have children after treatment. When we add chemotherapy, the fertility goes down by about 30%. What's complicated is it goes down by about 30% from where you start. So, for instance, if you have a testis cancer, and one of the things we do is when people are newly diagnosed, we talk to them about fertility, and you go and try to donate sperm, it's either going to work or it's not. Okay? So if you're unable to donate sperm at the time you're diagnosed, your odds of being able to have a child later are quite small. If you're able to donate sperm, and then you put it in a bank, your odds of being able to have a child in the future are actually quite good. So the people who that intervention is most helpful for, you know, it's a small percentage of people who can reproduce, but really if you're able to donate sperm at the time of your surgery, your odds are pretty good, you know, like 70% going forward. If you're unable to do that, there's not a whole lot we can do, but there are 30% of men who are able to produce sperm before that will have difficulty conceiving later on. So it does decrease your fertility, but it certainly doesn't rule it out. Okay, thanks.
Anybody else? Those are great questions. Holy cow, we have such a great community here. And give it up for Dr. Bernstein. That was an amazing presentation.
Thanks.
My hat's off to you. This is a very wise man.
Thanks.
We're very fortunate to have you in our community.
Thanks.
Thank you
Thanks for
so
coming, y'all.
much.